CAC scores even in their 70s and 80s.
And they have less coronary. I mean,
After
there is a
cirrhosis.
Hispanic paradox where there is
Exactly.
less coronary artery disease.
Exactly, and this African American paradox has been seen too with low CAC but high rates of CVD. So in women, the red line is kind of intermediate to the whites and to the other groups. But when you do the modeling of this data, when you adjust for all other risk factors, cholesterol, et cetera, even statin use, the men, you can see the comparison group is South Asians. South Asians and white men, the line overlaps one, so there's no difference. The whites and the South Asians have very similar CAC levels, but the other three groups have lower than the South Asians. The women, there's no difference. All four of the groups are very similar. This has been replicated and seen in the UK, in the Lollipop study. This has been replicated and seen in the Netherlands. So it's not a US phenomenon of our healthy group in Masala. We know that the CAC in South Asian men is very similar to white men. And this was kind of against my hypothesis going into the study, because I said, well, if there's going to be more cardiovascular disease, there's more CAC in these men at least. There isn't. When you adjust for everything, it's very similar to white men. Does that mean that's the end of the story? No.
Sorry, this was done at the follow-up time point?
No, this was the baseline.
Baseline time.
So now I'm going to show you the follow-up. Okay. You guys are great. I'm setting this up. Okay. My last 5 minutes.
Just take.
You sure?
Yeah.
Okay.
We'll combine the Q&A with a general discussion.
Okay, good, good. So then what we did is we brought them back, right? 750 people came back and we did the CAC again. And this is what I was interested in seeing, is there any change in how fast they develop CAC or how fast they progress? So we looked at incidence of new CAC in people who had 0 CAC scores. And we also looked at progression of CAC, so people who had non-zero scores, how fast did they move? And this is exactly 5 years of follow-up. And what we found for incidence, so these are people with no CAC at baseline, men on the left, women on the right, again, South Asians in black here. And you can see the South Asian men had very high incidence of new CAC, very similar to whites, but higher than the other groups. Women were all the same, okay. Interesting, I think, very interesting. And this is unadjusted, just, I think, age adjusted. So the white incidence of new CAC is similar for South Asians, so they're tracking very closely. And how about progression of CAC? Now, this is a really busy table, but I'm going to focus you right here on the red. This is showing you the men, and this is showing you different levels of CAC. 0 to 9, 10 to 99. Greater than 100 is what's clinically meaningful, because that's pretty significant atherosclerosis. And greater than 400 is very high. So what I want you to focus on is this very kind of intermediate, 10 to 99, and then the 100 to 199 South Asian men, women down here. And you can see the percent of people in this who, the progression to how much change in CAC they have is a much higher change in CAC for the South Asian men here in both of these categories. And that was statistically significant.
That's a 61, what does the number represent?
The number represents how many people, and the, actually, no, I'm sorry, it's a percent. It's a percent of people in each of these categories of CAC, okay? The percent out of the total that was in that group of 210. So the progression of CAC was faster in the South Asian men, especially in this intermediate 10 to 199 range than all the other groups. And this is change in CAC per year.
So a change
Per
to
year.
61 points, I guess those score going up by 61 points.
61% of South Asian
went up.
men out of 210, 61% had a CAC change of 10 to 99 per year.
10 to 99.
Per year. Per year. So you have to multiply by 5 because we divided by 5 because we had 5-year follow-up. So per year change in CAC was pretty high for 61% of men, higher than all the other groups, and this is significant. So
In the direction towards 100%.
right,
Yeah,
right.
yeah.
Exactly. And so here's the thing.
Are they on statins?
So a cardiologist, I knew a cardiologist would ask this question. There's a lot of people on statins because of all the lessons people have learned, and people are educated and they have health care and they're going to their doctors and they're on statins. And statins can increase CAC just as a side effect. Yeah.
Because the density
density goes up, exactly.
So where it says less than 0, does that mean that 8% of women had a regression?
Yeah, and part of this is not complete regression, it may be just a fault in how the CACs were read, and there was too close to 0. So I've talked to Matt about this. Matt was our reading center, Matt Rudolph at UCLA, so he read all of our scans.
You're measuring pixels. I mean, I guess some score is
Yes.
designed by the guy who did the Southbridge diet, and he just counted pixels.
Yeah, he's a cardiologist.
Yes. Okay, so then what we did is because of this question about are there more South Asians on statins, even this primary prevention cohort, and there are a lot of South Asians on, so we got rid of the people on statins, either at baseline or at exam 2, either or. And so this is the data for men only, among MESA and Masala without statin use, and the same thing is there. So it's not the being on a statin that's doing this. So the progression of CAC in people who had CAC already seems to be faster among men than all of the other MESA groups.
So, can you assume that the progression of coronary calcification equates the progression of arteriosclerosis?
Yeah.
Meaning, so then you're saying is you can have coronary calcification as an endpoint of therapy.
Absolutely. I mean, it's been used in trials as an intermediate surrogate marker, right? Yeah. And so regression is also another really interesting topic.
And do you consider any level of CAC clinically significant?
Over
Or is it
100.
over
Just
100?
over 100. Yeah, that's what the AHA, ACC guidelines use is significant is 100. So the overall, so what we did, because, okay, that was, again, these are data showing you the raw numbers of progression, only age adjusted and then without statin use. But when you adjust for all the other cardiovascular risk factors, smoking, diabetes, high blood pressure, they were all associated with development and progression of CAC. And when you adjust for those things, the South Asian and the white men look similar again, okay? But the absolute CAC progression as a person reading CAC scores was faster for the South Asian men.
Can you go back to the So I'm curious, the 5-year progression,
Yeah.
that 10 to 99
Yeah.
includes 10 times 5 years, which isn't clinically significant.
This
Or
is per year.
99, right, but
Yeah,
it
yeah,
could be
you're
10
right.
times 5 is
Yes.
50, it wouldn't be clinically significant. Lumped together with the group of people
Yeah.
who 1 year,
Right.
a 99 is significant for 1 year.
Yeah,
And
but,
I'm just curious
so
if.
look at this group, 100 to 199 in their progression. So, but we're, just showing you the stratified analysis here, these are the two groups that were really, highlighted to be different from the other groups. And they-
It's just difficult to compare a person with
Yeah,
a change of 10 per year,
yeah.
which
With a
over
99.
5 years wouldn't be significant, with a 99, which in 1 year is significant. So
Yeah, this is, we have to cut and dice our data in many different ways,
Yeah.
and this is.
We asked her to present those data
Oh, I get it.
early on. so-
No, I'm
It's early data, yeah.
And the progression.
We have 50% of heart attacks occur in lesions that are less than 50%, and 12% occur in areas where there is no obstructive lesion from the TIMI trials. But so because they are the soft plaque that are rupturing, not the heavily calcified plaque.
So I'm going to end with 2 slides, and that's showing some of the policy impacts we've had. We've helped influence the ADA to change the BMI cut points to 23 for Asian Americans to be screened for diabetes. That's pooling our data with other Asian American studies. And then the new guidelines you're all aware of. South Asians are now considered a risk-enhancing factor, that you should consider using statins earlier if you're treating a South Asian person. And the biggest news that I hope you all are aware of is Representative Jaypal in Seattle she's sponsoring a bill, HR 3131, about raising South Asian health, heart awareness, and a research act. And this is going to be great, so please promote that. So here's our list of conclusions. I do want to leave with, the glass half full outlook is that there's several risk factors that can be modified, and it's not, inevitable in any way. Better dietary patterns, more exercise, stabilize the density of your plaque. Moderate traditional cultural beliefs, that's actually protective. I didn't show you our acculturation data. Anxiety and stress, we found an independent risk with atherosclerosis with higher levels of anxiety and stress, so there is some great ways to intervene on that, please check out our website, and thank you all for engaging in the conversation.
Amazing. I think that we're going to hold on more questions for Dr. Kanaya, since we kind of interjected in her talk, so we can move on to Dr. Molina. And I think she gave a perfect setup. So Dr. Molina is a cardiologist and intramedicine and trained here at Stanford before he went on through many things in his career to finally landing now at El Camino Hospital, and then starting as a co-founder of the South Asian Heart Center. And I think that the kinds of things that Dr. Kanaya is mentioning about lifestyle changes has really been a focus for the South Asian Heart Center and Dr. Molina, and thinking about how to make a real community-based intervention for patients, South Asian patients, and as well as thinking about screening, which I think is going to cover both of those today and some of the data that they have. So just to save time, we'll jump right in, and again, we'll do questions at the end, I think.
So thank you for having us over. Today, what I'm going to do is going to sort of show you the evolution of how we have developed the South Asian Heart Center. The South Asian Heart Center now is about 13 years old. And it all started as a result in around 2006, but it resulted from our experience in the emergency room at El Camino Hospital. El Camino Hospital is in the middle of Silicon Valley. It's in Mountain View, where Google is based next to Cupertino. And I'm an interventional cardiologist, and we were seeing young South Asian engineers, typical 44-year-old South Asian engineers showing up with 2 kids in the waiting room with their wives, having an acute MI. And coming from an education where you study the Framingham trial, we couldn't believe that these individuals, without a smoking history, without hypertension, and without impressive hypercholesterolemia, were having acute MIs. So this is actually the data from that preceded the creation of the South Asian Heart Center. We were seeing that about 6% of our patients in the emergency room were South Asians. At that time in our community, South Asians accounted for no more than 3% of the population. And we actually had the youngest MI patient in those 2 years, who was a 24-year-old South Asian man. I'm in the process of taking care of a 39-year-old South Asian man who just recently presented to my practice with an acute MI with 3-vessel coronary artery disease. So this led to the creation of the South Asian Heart Center. It was created by the El Camino Hospital Foundation. And it actually, our mission was to reduce the high incidence of diabetes and heart attacks. Initially, it was mainly coronary artery disease and heart attacks, and the diabetes came along with a culturally tailored, science-based, and lifestyle-focused service. And we did this through outreach, prevention, education, and research, and we'll talk about what we have done in these 4 spheres. What we did is we created the Aim to Prevent program, and what we wanted to do was to assess the risk of cardiovascular disease through advanced screening. We wanted to intervene and make a change, and then to manage through heart health coaching. And that actually was the basis of what led to our South Asian Heart Center formula for the dealing of this epidemic of coronary artery disease. Our center does not practice medicine. We actually do not use ICD-10 codes. We don't take so-called insurance. We have very low fees initially. For the first 7 years of the South Asian Heart Center, our services were completely free to the individuals who came in to our center. Now we have a small sort of service fee for the services that we provide. Now, our main problem when we started was that we did not know how to predict cardiovascular disease. We were educated using the Framingham formulas, and we became very much aware that these formulas were not going to be predictive, and that actually, in fact, were under-predict the incidence of cardiac events in this population. So what we decided to do, and actually, was then to look for arteriosclerosis. And I'll sort of show you how we did that.
Now, this is sort of the thinking that was going on as we were creating our curriculum. We realized that if you look at LDL per se, LDL cholesterol is a very poor marker or risk for coronary artery disease. That is, that in individuals presenting to a hospital with acute coronary syndromes or acute MIs, 83% had LDL levels below 130. 50% had LDL levels below 100, and 18% had LDL levels below 70, which is actually the aim of therapy for statin therapy. When we actually look at HDL cholesterol, we actually got very sort of similar results. 45% of people showing up with acute coronary syndromes, and this is about 140,000 patients, actually had HDL levels over 40 milligrams per deciliter. Regarding triglycerides, 70% had triglyceride levels below 150. So this lipidemia, as defined then, was actually not accounting or explaining the presence of acute coronary syndromes when we sort of look at this data. So we thought, well, we had to do something better. And that led to our screening methodology. So obviously, being a South Asian Heart Center, we actually look for ethnicity, we look for family history, we actually did a diet history, exercise history, tobacco use, we assessed stress, and we did a very simple biometric examination looking at height, weight, calculated body mass index, waist circumference, and we actually measure blood pressure. Subsequently, and as part of that, we also did a laboratory evaluation, and we actually threw in, at that time in 2006, the kitchen sink. Whatever was available, we tested it. So we did the typical NHANES lipid profile, total cholesterol, HDL cholesterol, LDL cholesterol, and triglycerides. We look at metabolism, look at blood glucose, we A1C, insulin, and we now are doing an oral glucose tolerance test. We look at homocysteine, and then we thought, okay, we'll do advanced lipid testing. We look at ApoB, Lp(a), LDL size initially with Berkeley Heart Labs, and then subsequently with ion mobility, and we look at then inflammatory markers, fibrinogen, but ultimately we just stayed with HSCRP. And what happened as we went along, and as a result of the suggestions of our scientific advisory council at the time, we actually incorporated coronary artery scanning. And this has actually been a little bit difficult to roll out because most of our participants have been concerned about radiation. So we came up with some rules. You had to be, for a man, you had to be over the age of 40. For a woman, you had to be over the age of 45. And you had to have at least one abnormality in any of these parameters. But actually, that was very easy. Less than 6% of our cohort had a completely normal lipid profile and a completely normal evaluation. And this is why we did it. We actually realized when you use the typical formulas that are available, the Framingham, or now ASCVD, or the PROCAM score, which is the same thing as Framingham but arising from Germany, we actually found that most MIs occur in the intermediate risk group. So that's why the American Heart Association and the American College of Cardiology in November of 2013 said, okay, before we were suggesting to treat with statins people at high risk. Now we're going to suggest to treat people with individuals with intermediate risk. So now anybody who has a 7.5% chance of having an acute vascular event, stroke or heart attack, should be considered for statin therapy. And that is actually the present recommendation. Problem with that is that every 65-year-old American man should be on a statin according to those guidelines. So you're treating a lot of people who actually, when you think about only 50% of the population dies of an acute MI, you're treating 50% of the population who are taking statins for no, they will not receive any benefit. But that is different when you're looking at coronary artery calcification. And you actually can predict on the basis of coronary artery calcification who is really at risk. So then you really those are the individuals who actually should be treated, and in those individuals you do full course therapy for the prevention of coronary artery events. And this actually, we actually talked a little bit about this this chart, and that is, this is the mortality rate and the event-free survival of depending on what your coronary calcium score is. This is at 40 months, and you can see that those who have a calcium score of 0 have an excellent prognosis versus individuals who actually fall between with a calcium score greater than 0 but are less than the 75th percentile, versus individuals who actually are above the 75th percentile. That's from the MESA, the MESA database, which actually the Masala trial sort of follows through, particularly for men. They're very similar. So this is actually our evolution. When we started, we decided that we were going to initially provide a service to the community, as described here. We initially attempted to aim at identifying factors responsible for the coronary artery disease epidemic. We developed an expertise in behavior change, and we moved away from just identifying risk factors to making the diagnosis of coronary arteriosclerosis. We then, in 2016, about 3 years ago, realizing that there are dual epidemics of both coronary artery disease and diabetes, and that this metabolism may be the main driving force, as Alka showed you, about over 60% of her cohort of men have actually this metabolic situation, either frank diabetes or pre-diabetes. We then realized that we have to tackle the problem of diabetes, and we then created, based on the diabetes prevention program, we have actually created a culturally appropriate diabetes prevention program aimed at South Asians. Something that is missing there is that we have opened the South Asian Heart Center to the whole population. That is, we do not, there's ethnicity is not a filter to come in to the South Asian Heart Center. Anyone can participate in our screening and coaching program that has also permitted us to provide this program to corporations where all their employees have access to what we do. Now, we had to create a lifestyle curriculum because we decided that we were going to approach this from the lifestyle point of view. And I'll show you the data of why we decided to do that in a moment. And probably this is actually all news for you. This is all, all very old data. This is data that has not been captured in South Asian groups. This is actually probably typical, white America. But we went back to the Alameda study. So the Alameda study was published in 1980, and it was a 25-year-old study, prospective study, looking at factors associated with successful living, that is longevity and being self-sufficient and independent. And they studied 7,000 subjects. They found 7 habits: adequate sleep, 7 to 8 hours per night, regular vigorous physical activity, maintaining a recommended weight, no smoking, none or moderate alcohol consumption, moderate being up to 5 alcoholic beverages per day, so 1 beer less